Congratulations. This is the Quality Improvement Award, and with me are Natalie Metcalf, GP partner at Holderness Health, and Heather Whitfield. And this is the Gold Team approach to improving palliative and end-of-life care in general practice. And the sponsor, Daniel Ratchford from IQVIA. Just to say a few words.
Thank you very much, Victoria. Congratulations.
Thank you.
Thank you.
We had over 370 entries for this award, so it was really, really highly contested. Very difficult for our judges. What the judges were particularly looking for were quality improvement initiatives that weren't just about a single project or a single program, but a genuine change in culture in a whole organisation that involved everybody in the organisation and a whole team. We found that a lot, and congratulations again to our regional winners who were brilliant. But in Holderness Health, what we found was a real commitment and a passion for quality improvement at a really critical and really sensitive time of life for patients and their families. So congratulations.
Thank you so much.
Well done. And we were saying just before we came on, palliative care often doesn't get the recognition that it deserves, and so many of us and our relatives will need it at some point. What was the gap that you'd identified?
So I think this came to light because of patient feedback, actually. So particularly after the pandemic, we recognised that continuity of care had fallen by the wayside a little bit, but particularly for our palliative patients, they felt as though they received a diagnosis in secondary care and then would often not really see the primary care team until there was a crisis and until they needed acute immediate intervention. And we could see that there was a window of opportunity there to create some continuity from really the point at which the patient was referred for diagnosis, with a suspected diagnosis, and then particularly once they were discharged from hospital or any other setting, to try and get in there and be proactive in our delivery of care, not waiting for the crisis to come about, but predict that actually there would be a problem, there would be bumps in the road, and how we could best engineer a system that would allow them to access us easily, support them along the way, and to make them feel as though we were part of that journey with them and that we cared. And it's been overwhelmingly well received. And as part of this, it's been a project to see where we haven't been delivering that care, to see how many patients who have a palliative diagnosis that perhaps we haven't been in contact with, and try and identify those patients and improve from there.
How do you make this sustainable?
It's been about embedding it, I think, and it's what started out as some small improvements has really grown into a program of improvements, and making that an everyday occurrence for what we do for that group of people, and not just about the clinical kind of approach. It's about supporting the people holistically. People struggle with all kinds of things. Navigating care can be really difficult for people, particularly in that group. So it's about making everything as easy as it can possibly be for that group of people. We've really developed some partnerships with our kind of neighbourhood partners and services that have really made that possible, and has meant that we've been able to make real improvements in that, and to get really quick answers for people when they've got queries or problems, and just to know that there's somebody there at the end of the phone who will answer quickly, and if we don't have the answer, we will find somebody that does have the answer for them.
I mean, I was going to ask, though, to carry on from that, is give me an example, a sort of made-up hybrid patient or something about how it works.
Okay, so typically what happens, obviously we receive notification of palliative diagnoses from multiple streams of care providers, but when we receive notification of that, wherever it comes in through, we highlight this patient as a gold patient. So their record is immediately identified as gold, which brings to the forefront of anybody answering a call about that patient that they're gold and they get priority access to us. We review their notes and see whether they've had contact with a GP or who their registered GP would be, and then our gold team would typically contact them and ask them if there's a GP that they would prefer to have continuity of care with and allocate that GP to them. And then we've set up a system whereby our GP and clinical staff will arrange follow-up either appointments or typically home visits, given how frail and unwell this group of patients are. In between those follow-ups, we'll have our GPA team who will conduct a call. So a non-clinical call, but it's really a check-in to see if anything's cropped up since the last GP contact. And then obviously they've got a direct stream into the GP team to highlight those issues. I think really part of the success of it is just identifying the patient, knowing that they have this palliative diagnosis, knowing that they're going to be on this journey and we need to support them the whole way. And it's really improved our continuity provision. It's really improved our responsiveness. But again, going back to that proactive approach, it's not waiting for the disasters. It's trying to expect them, talk about them, and have those proactive discussions about what's going to happen, so that it eases the fear along the way.
How do you measure the quality?
That's a good question. I think in primary care, it's very common for there's a lot of feedback avenues for patients to come through. We're always looking for patient feedback because, you know, we can we think we know what people want, but I think unless you get that feedback from them and from somebody in that position, so we're always looking to see what we can do better. If we implement something that doesn't quite hit the mark, we will look at that and make changes to that. And it's a really sensitive subject, and what one person is really happy to talk about, for another person they find that really difficult. So it's about that kind of continuous improvement kind of mindset, curiosity, and really just seeing what else we can do to ease the burden for patients and families.
What sort of numbers are we talking about?
Well, that's a good question. Off the top of my head, how many palliative codes have we got?
So I think we've got around about the 200 mark, I think.
So there's still work to do here. So part of the initiation of this project came about, firstly, from patient feedback. Secondly, when we did searches across our data to look at our palliative diagnoses, we found that there was, you know, in comparison to other national averages, we were probably underrepresenting our palliative community. So we've had a huge drive actually to identify our patients who are palliative or who probably should be considered as palliative, but we haven't had those discussions with them. That's been really difficult because, as you can imagine, it's one thing to leave hospital with a palliative diagnosis because the consultant oncologist has told you that's the case. It's the other to have a GP contact you and try and create those conversations to say, you know, we need to think about the next 12 months when somebody perhaps hasn't thought about the next 12 months and how that might look. But through doing that, I think we are improving patient care and we're being, you know, as proactive and as helpful as we can be, rather than leaving it to the final moments. It's not for everybody. The discussions are incredibly sensitive and difficult and sometimes unexpected. But I think through this initiative and creating this cultural mindset that we've got at Holderness Health, we're trying to make everybody open to those conversations because they do inevitably have to happen at some point.
Is there a next step?
I think, as Natalie said, you know, the next step is to continue to make sure that we're identifying everybody that would benefit and that would like to be involved in having those discussions. And we don't feel like we're there, definitely. You know, we don't feel like we've got everything perfect. So
I think that's an important thing to admit, isn't it?
It is,
because
absolutely.
There will be little bumps along the road, won't there?
There will be, absolutely. And I think it's important to recognise those and to have those honest discussions where we need to, and just really see what else we can provide, as I said before, just to make that journey a little bit easier for patients and families.
Yeah, and it does give it more profile, which I think is important, isn't it? Even just by winning this award. Well, listen, congratulations, both of you, and thank you so much for taking the time.
Thanks so
much.
No
problem.
Thank you.
Thank you.